This
call
conference will now be recorded.
we don't call the ULTRATOOTH an implant, and the reason for that is, traditionally when patients come to you and ask for a tooth, we basically had to uh, introduce them to dental implants and tell them that the way it works is that we have to extract the tooth, let it heal, place, and introduce them to all the steps of implantology. And that's what's been happening past 30 years. But in the world of UltraTooth, in 1994, uh, the FDA, US FDA, cleared it for full functional immediate loading. And this is still the only device that has been approved for full functional immediate loading. And I actually categorize it as a separate category. When we went ahead and applied for FDA approval uh, in 1992. This is an article that I wrote in 1991. I introduced it first and actually used the term immediate load for the first time. And at that time, I copyrighted the term and described it as full functional loading at the time of placement. Now, when we went to the FDA in 92, at that time, and still, as long as you make a screw uh, which is made of titanium, you can claim to be similar to the original brand mark, and you get your FDA 510K approval. And we tried to do that in 1992, and the FDA rejected us because of two reasons. One, the design was not the same, and secondary thing was the demands were not, the claims were not the same, and we claimed full functional immediate loading at time of placement. So FDA forced us to do basically what Brandmark had done and submit clinical data to show the FDA that we can back up our claims. And 3 years data were shown in 1994. This device became the first device and still is, which is approved for full functional immediate loading. Now, if you Google this, you'll see it in your browser. In 1998, this status was challenged by the other companies. There was a meeting in Washington with the FDA, and basically the topic was that why certain implants are making certain claims. So when the panel discussed the Sargon implant, this is a Sargon type implant, which the latest version is the ULTRATOOTH. When the panel discussed this and when they were questioning why is this device the only device that has been approved for full functional immediate loading, the highlighted area shows that one of the doctors on the panel says that this is the only device after original Brandmark had submitted clinical data to obtain its claims. And at that time, they put it in a different category, which is a root form with special characterizations, and the special characteristics being full functional immediate loading and being an active implant, in other words, having anchorage device, expandable. So when someone comes to my practice and asks for an implant, I tell them that we do have the implant. Bioden manufactures implants, and implants, take time, and this is what we can do. But if you want a tooth, we also have the UltraTooth, and the UltraTooth, we can replace your tooth immediately, and here's the price. And typically, in my practice, there's between $1,500 to $2,000 difference between a regular implant and the UltraTooth. Now, even though the steps and restoration is much faster, it takes less time, you'd be surprised how fast the patient will agree to pay more when you approach them and tell them that we'll give you a tooth right now as we're removing your tooth. So if you look at the UltraTooth design, this is something that has evolved for past 28 years. Now, we the bottom half of the UltraTooth has basically been the same. The only change that has occurred there is that if you look at the threads, they kind of disappear at the bottom. And that's the design that allowed us to make it self-tapping. Originally, the threads were large, the same size, and before you inserted the implant, the ULTRATOOTH, or the Sargon implant, you had to tap the site, form the threads, and some doctors would not do that in hard bone. They would use the implant to, thread the bone and actually would bend the pods. So we changed the design at the bottom and we made the threads disappearing. So the thread starts engaging towards the midpoint, the top, which has more bulk. So that made the device self-tapping. And so this is the only difference that you see at the bottom. In the bottom area, we have an expansion screw, which is a slotted screw, and it takes a slotted screwdriver. And the reason for the slotted screwdriver is because it's designed such that you always put 20 newtons of force, torque wrench on the screwdriver to expand it, regardless of what location you are. It's always 20 newtons, and depending on the type of bone, the pods will expand differently. Less expansion in harder bone, more expansion in softer bone. But the expansion is always 20, and as you get to 25, and if someone overdoes it, you can never damage the head of the screw. The worst you can do is bend the screwdriver, which is designed, the tip changes. You can unscrew it and put a new tip on it. So the system is designed such that you can never do any damage to this mechanism. So as you turn the screw, it will pull up what we call the expansion cone. And as the expansion cone moves up, it pushes the pods out. So that's the design. Now, the top part has gone through different changes, and we went through with the original Vandermark hex, and the first design had the hex bevel, but because of the market demanded the original hex, we put the original Vandermark hex. Then we went internal hex, we went tapered implant, and all of these designs, looking back about 8, 9 years ago, uh, I realized that the first 100 Sargon implants that I placed, which were cylindrical, had the best result. When we tapered the implant outward, that in aesthetic zone always caused the soft tissue to recede to the top of the implant. So if the device was the Sargon implant was placed at the right level, the tissue would be right. But if it was placed slightly deeper, the tissue would not match the adjacent tooth. And that being because where the bones is supposed to be supporting that soft tissue, we'd replace it with metal, which metal tapered out. So looking back at that device, we realized that the cylindrical device design was the best design. And one thing that we did, we changed the top, and actually this is a one-piece device. So in other words, ULTRATOOTH, when you say it's a 13 millimeter, the length starts from the threaded area, and the top, it has an abutment on it. So when doctors look at it and say this is an external hex implant, it's not. It's actually an abutment, and the abutment, we call that a hex Morse. So two purposes for this is that, first of all, in posterior region, you can use this as your final abutment. So your crown finishes anywhere on this bevel. Now, if you need any extension, the carrier is an abutment, and also we have different sizes of abutments that basically extend this portion of it. But the way they extend it, they mate to this Morse taper. And that means when you tighten the abutment screw, when the Morse taper engages, these parts cold weld, causing the two pieces to basically cold weld. And this means that it will never loosen, the abutment will never loosen. And at that point, you can actually remove the abutment screw, and these two are welded. So if you ever want to remove the abutment, there's a abutment remover that you screw in, and it just lifts the abutment. So, and also we added the additional feature of having the screw cap, which is basically the cover screw, but it's more tapered. So after expansion, you tighten, we put this cover screw, and it just more tapers and seals the top of the implant. So there's no way bacteria can come through here, and you have another seal at this screw level. They can't go through here. And the third seal is if you put the extension abutment. So we call this a triple seal. Bacteria will never find its way inside the implant. For those of you who open abutments and healing collars, you smell and you see what happens. And sometimes if that junction is put in a little deep, you see fistula, soft tissue fistulas, and all that. You will never see that with the ULTRATOOTH. So that's the latest design. Now, we do have papers that were published on, this is 273 implants that were reported on 40 months by Hobo and Joe, and they showed 98% success rate on the maxilla, 96% on the mandible, and actually on the maxillary extraction sides, they had 100% success rate. So here's the how the ULTRATOOTH comes. This is a carrier that comes with it. So the ULTRATOOTH is attached to this. So when you drive the ULTRATOOTH in and expand it, this carrier can play several purposes. One is it can be your final abutment, a provisional and final abutment. So if you cut it from here, make it look like this, basically this is your final abutment. You got your margin, you can scan it, or take impression, put a core, take impression, and finish the restoration right there. So, or this can be an impression post. If you're doing several and you don't want to sit there and cut, what you do is use this as an impression post, take an impression, and there's a provisional abutment inside the same box, which you can put it and make your provisional on while the lab is cutting these and making your final prosthesis. So here's the restorative options.
That's so nice. Just ask me what you'd like me to do, and I'll try.
These are the restorative options. We have a small abutment that goes on top of this. The small abutment is ideal for lower anterior teeth and maxillary laterals, even though you can use it everywhere. Sometimes I even use it for molar or maxillary anterior teeth because it's small, but it does have a strength. You can put a zirconia crown on this thing, and you don't see any of the abutments showing through. So if you have smaller anterior teeth that you're concerned with the abutment showing through, use this and it'll serve the purpose. And this is the small abutment that replaces the provisional abutment and the cover screw or the screw cap. So when you're using the small abutment, you don't need these two. You just close in here and more tapers, and that's it. So this restorative system is very simple. As I said, impression post, or you can take a sleeve impression, implant level impression, and have the lab, decide for you what they want to do. So here are the three options. As I said, the top already has the abutment, 3mm abutment. You have the small abutment option, and you have the standard abutment, which is preferable. You can adjust the margin and finish it with that. So depending on the size of the teeth, you can decide which way you want to go. So now, traditionally, when you come in, and I speak to some doctors about this device, often I see doctors that tell me that, I do have the ideal implant system, and basically I can do anything I want with my implant system. And my answer to them is great, continue using your implant system, but I'm going to give you 5 things that your implant system does not do. And if these 5 things interest you, then you might want to consider the ULTRATOOTH, adding ULTRATOOTH to your practice. And number 1, as we discussed, is the full functional immediate loading. So what do we mean by full functional immediate loading? Full functional immediate loading means that patient comes to you, and 90% of the time, you can go in and say, yeah, I'm going to take that tooth out, and I'm going to give you a brand new tooth. Now, these are teeth that can have apical lesions, These are teeth that can have missing buccal plates. These are teeth that can have periodontal lesions, and these all can be treated. And I'm going to give you a quick sample of these. This would be, for example, an apical lesion. These were placed, and you can see 7-year results. And what's very important is the stability of the interproximal area and the papilla. This is teeth number 8 and 9 that were treated. And I want you to pay attention to the interproximal area. And if you just overlap the bone, this right here is the important part where we're going to talk about what's going on here for this papilla to be there 7 years later, in this case, the picture that you can see. Now, you've all been told what not to do with dental implants when it comes to 8 and 9. You know, they don't put them next to each other because of this black triangle. But we're going to show you that. Now, quickly, I'm going to show you a case where has a buccal fistula. The buccal plate is missing. It has an apical lesion. This apical lesion goes to the lateral, overlaps the lateral, and by the time I extract the tooth, that piece of root will stay in there. And when we're going to flap it, when the buccal plate is missing, the only difference in the surgery, the steps are all the same, except we do one vertical cut and we flap it. We make sure that we remove any cystic tissue, any root pieces, and we have complete bone around there. Right here, this is flapped. Now I'm removing that little piece of root, and then we curette inside that socket and make sure everything we're dealing with is bone. So now, right here, we're going to make a brand new socket for the implant. We use the universal drill. This universal drill replaces our rosette, pilot, guide, and takes us all the way to the final diameter. So it does the job of 4 or 5 drills. So right here, with one shot, all I have to do is make sure that the direction is the same direction as the adjacent tooth. I'm coming out of the incisal area, and it's basically parallel to the old root, but slightly palatal. And then the next drill is the final drill. And this preparation is done. A third drill for the larger teeth is just a emergence profile that takes away the bone of the coronal region, because we don't want any pressure on that coronal region bone, because that causes resorption. And we want to make room for our abutment and restoration. So now this case, we go ahead and expand it. And this was several years ago where we had this material called Dystania. We were testing it, and it was a hybrid material where we're making crown shells, and we're making final crowns on the aesthetic zone. So what you'll see here is I'm going to deliver a final crown at the time of the placement of the implant. Here, what we're doing is that after the device ULTRATOOTH is placed, we go ahead and graft. I'm using BioOS collagen here. It comes in blocks. You cut a piece, and if that gets wet with blood, you can kind of mold it to the shape you want. And I'm just shaping it as that buccal plate that was missing. And then to protect it, you can place your membrane. In this case, you can use any resorbable membrane. In this case, I'm using calcium sulfate and tetracycline as my membrane. Now, the only secret to use of calcium sulfate and tetracycline is that you just have to let it dry. You need a dry field, and then once you're shaping it, you just put it 2 by 2, leave the room for 4 or 5 minutes, and when you come back, you should have that initial set. This is where it is, and then I'm going to go ahead and suture the soft tissue exactly the way it was prior to surgery. So here we're suturing, and while we're doing this, the lab is actually making the final crown. I took an index of the implant, and they used that index to mount the analog on the model that they had, and they're making the final crown. So by the time I'm finished doing this, I can actually place the final crown on this ULTRATOOTH. So here we're just cleaning the area, and you'll see me deliver the abutment and the final crown. Now, as I said, this is a ceramic, it's a hybrid material, and it draws color from the surrounding tissue. So as it heals, you'll see the color match will be better. So essentially here, we delivered the final crown, and this is how this looks. So this is immediately post-operatively, and regardless of whether the buccal plate is there with graft or not, as far as the stability of the implant, it takes its stability from its apex. So the ULTRATOOTH is stable enough to put full function at the time of placement, so you can have the patient actually bite an apple right there. So the instruction for this patient post-operatively is enjoy. And what we're going to do is show you the healing down the line. So this is 10-day post-operatively. And if you tap on it or you do an ISQ, you will see if with an ISQ test, before expansion, you're in the 20s and 30s. When you expand it, you're in 65, 70 range, and it just stays there. It never changes with time. So here, it's 6 weeks post-op. We remove the crown to show the healing here. And this is where we are in 6 weeks. And radiographically, I want you to pay attention to where the bone is in relation to the first thread. So the first thread being here, and just follow the bone coming up. Now, this is 4 years post-operatively, what you saw. Now, this is not an aberration. This is the norm. In other words, for those of you who use the ULTRATOOTH or will be using the ULTRATOOTH, this is the desired result. This is what you expect. This is not an exception where you get an exception, show it on the podium, and then when the doctors go ahead and use the system, get different results. Here's the other um, problem, which is periodontal problem. This patient is a pretty famous singer. Got married, went to Europe, divorce, depression, and severe periodontal disease. And everywhere she was going, they told her full mouth extractions, dentures, and one night her sister was watching TV. She saw us on TV and called her, said, I think we have the answer for you. So when she came in, at first I just did these 4 anterior teeth to build some confidence in her, and then eventually we did everything except a couple of teeth that are here. So here's where we are. You can see radiographically the periodontal lesions. The only thing it means when I see a case like this, I know there's a junctional epithelium that is covering the bone. So basically, I take a cutting. I basically come here and take a scalpel and cut this junctional epithelium from top, and I just pull this whole thing tissue off the bone, exposing the bone. So if there's a lesion here, I know there's junctional epithelium here. I cut on top, and I just basically out. So when I'm done cleaning this pocket here, everything here is bone. If you leave any of this junctional epithelium there, that pocket will remain around your ULTRATOOTH. It's not going to fill with bone. So essentially, that's the protocol. You just clean it. If it's an apical lesion, same thing. If it comes out with your extraction, that's easier. But if it doesn't, you have to go in there and make sure that apical lesion is out. If not, it will grow around your ULTRATOOTH when you place it. So here, these are the lower teeth. So we place the ULTRATOOTH, and just graft the socket, making sure that the contour of the soft tissue is maintained. Here is a provisional. This is years ago where we did gold custom abutments. This is delivered, and you can see the healing here. And this is at the time of framework try-in. I mean the final try-in before cementation. This is the entire mouth done. A couple of teeth are natural teeth here. And essentially, you can see 12-year post-op here. And again, pay attention to the level of the bone in relation to the implant. So when we do immediate replacement, obviously we can show that we preserve the original emergence profile. So if I take a tooth out and place the ULTRATOOTH and put a provisional or a final crown, if you have a milling unit, you can directly make a final crown and cement it. We can show that we can preserve the emergence profile. But what's important is that the question is that can this emergence profile be maintained? So think about it. When we have situations with a screw where a patient comes through and, a lot of times you have to, in the aesthetic zone, you have to do bone grafting or soft tissue grafting, recreating this papilla and putting the final crown, but the implant by design says it loses 0.2 millimeters of bone per year. So basically, we know that 10 years down the line, we're going to have threads exposed and we're going to have the loss of that papilla and soft tissue. Some of you are going to say, no, I have some implants that have never lost bone. And if you pay attention, those are normally in the posterior region where the forces are directed to the long axis of the implant. But as the implant comes in the anterior, especially the maxillary region where the forces are coming laterally, that's where the problem occurs, and then the soft tissue and hard tissue loss. Now, I feel that one of the best feature of the ULTRATOOTH is the Eiffel Tower design of it. And very early in treating cases, I noticed that the coronal region of the implant did not react like typical implants. In other words, the bone did not go to the first thread and with time go down. I mean, the bone would just stay and grow and fill the socket, many times passing the collar and sometimes even covering the abutment. And this was shown by studies. The reason for it was, I mean, we want to stay away from cases like this. This was a problem. I mean, it's a screw that came in. With time, you can see the bone loss and the show of the implant through the tissue. So photoelastic studies very early told us the difference in design, and when you put a cylinder versus an expandable device, you can see the forces that are at the apex. Now, when you put lateral load on it, when you take a cylinder and put a lateral load on it, it's normally in the crestal region. And the minute the device is wider at the apex, when you put lateral load on it, the force is transmitted apically. This was done in UCLA, and it shows it clearly. When you put that lateral load on the ULTRATOOTH, the entire pressure is at the apex and nothing on the coronal region. So, and there is the finite element analysis that was done by a competitor comparing 3 types of implants, and they were manufacturing this pinned implant. Even there, they showed here that out of the 3 devices, the expanding implant showed the most favorable stress distribution. And that meant that the ULTRATOOTH, when I look at cases very early in treatment, and I was looking at them here, and looking at cases where the bone was passing the collar and actually going to the abutment. The reason being was basically this was the only device that had that Eiffel Tower design and was wider at the apex than the top. More recent cases, you can see these severe periodontal cases. With the bone loss, number 6 is actually a healed site. So in these situations, when we replace these teeth, the best we can promise the patient is to maintain the tissue where it was. So this case, this is a healed site, number 6 and 7 and 10. But again, I want you to pay attention to the coronal region and the bone healing pattern in the coronal area of the ultratooth. So looking closer, this is typical healing for the ultratooth. Again, repeating that this is a result that I would expect every single one of you, if you use the ultratooth, to attain. A case where a patient came in with a fractured bicuspid, and these two had to be replaced. And I used a screw to tent the floor of the sinus here, and I used the natural tooth molar, fixed provisional. Patient was wearing fixed provisional where this implant was healing. Then when we delivered the final appliance, we splinted these 3 implants. But I want you to pay attention again to the coronal region and see the maturity of the bone in the crestal area. Now this screw is doing as good as it can, normally that bone goes to the first thread. We did a study on 50 ultra teeth with that material that I was talking about, and we did immediate tooth replacement with final crown at the time of placement. Now, everything was fine until the 6th, 7th year, where these crowns started fracturing. The material started having problems in the 6th and 7th year, cracks and fractures crown. And this was one of those cases. And it gave us an opportunity to look at the ultratooth 6, 7 years down the line when we were changing the crown. So here, if you took this is a time of impression taking. I want you to pay attention to the emergence profile, to the papilla 7 years down the line. Now, these crowns were changed, and this is the same patient 14 years down the line. I want you to look at the bone pattern. I want you to look at the bone pattern 14 years later. Again, this is not what we're used to seeing around traditional implant. This is the margin of the crown, ladies and gentlemen. This is where the crown finishes. So tell me again about peri-implantitis. When we place a screw and we know that the bone is going to start at the first thread, as soon as it craters, we go in there, we look for bacteria. That's a perfect place for bacteria to live. And we call that peri-implantitis, and it goes, as it keeps going down, we blame the patient about that, and we tell the patient that you're not cleaning it well. Well, no, by design, screws will lose bone, and that peri-implantitis is actually iatrogenic. So what we're saying is the world of ultratooth, there is no peri-implantitis. So this is another patient that came in, everything was done fine, and this is, you see the bone dipping down, and here's, as the bone goes, there is no blood supply, and now the patient is wondering what to do here. This is an interesting case that I did 25 years ago. And those days we didn't have sinus grafting, and we did these funny things where we put long implants behind the sinus and we put some implants in the septum. At that time, this patient, when I did the restorations, she came in and complained about this region. A buccal plate had not healed on this one. And we learned that when the buccal plate was missing, as I described to you, we should flap and do it. And at that time, we used to do everything through the socket. And sometimes this buccal plate didn't heal. So when I completed this case, this patient complained that when she was pressing this area, she could feel some pain, which the soft tissue was being pressed against the threads. This was a lady that came in with her son. So this patient disappeared. And a couple of months ago, I see her with her son sitting in the chair 25 years later. And I asked her, I looked at her, I said, where have you been? She said, home. I said, who's been taking care of you? She said, what do you mean? I said, who's your dentist? She said, you. I said, well, when was the last time this thing was cleaned? These implants were cleaned. She said, what cleaning? This is implants. I never got cleaning. I just brush it myself. I said, so what are you doing here? She said, remember I told you when I press this area, I feel that pain? I still do. 25 years later, I went ahead and grafted this area. So this is essentially, look at the bone pattern 25 years down the line. So fourth benefit, University of Indiana, which did the animal studies, we have several sets of animal studies which were done in France, University of Indiana, some in Japan. One thing that they all showed is that when this pattern that you saw with the photoelastic study, you see this circular region, it translated into same circular region, increased bone, and they call it an oscillation effect. Now, oscillation effect meant that circular bone increasing, and also they hypothesized about like a tuning fork effect of these pods as the patient chews. They said this area is constantly being stimulated, and you're getting these circular area of increased density. Now, clinically, what it meant it gave us an answer because typically when you use the ULTRATOOTH, I often have doctors that call me and I see it in my own cases that say they're treating a tooth number 8 and number 7 has some mobility and some bone loss. And by treating tooth number 8, they come back and say, you know, I treated number 8, now number 7 is no longer mobile and it's doing better. And that's what it's doing is the ULTRATOOTH is stimulating the surrounding bone and improving the bone quality in the surrounding region. Now, this is a pretty famous actor that had gone to a periodontist, had 2 traditional implants, and this bone loss and went back to the periodontist, and the periodontist gave him an almost 2-year treatment plan where he told him that he had to take out these implants, extract this tooth, and graft the area, and then later replace the implants. And by the time they restored it, this was like 17, 18 months later. So, and he had to wear a flipper the entire time. The patient came to our office and we went ahead. All we did is take out this tooth and place the ULTRATOOTH. I cleaned the adjacent area, refreshed the surface of this implant, the old implant. Refreshing meaning just took a diamond and refreshed the surface of the implant, grafted the area, and we placed another ULTRATOOTH on the other side, which he needed, and he left the office in one appointment with fixed provisional. And 3-4 months later, when the dentist, believed that this was actually bone, he went ahead and restored the case and finalized it. The patient was never in anything removable. But what I want you to do is to pay attention to this region, which now no longer needed to be replaced. These devices did not need any replacing. And look at the bone healing with the ULTRATOOTH and the effect on the surrounding region. Here's another case. This patient came, female, teary-eyed, she's sitting in the chair. She told me a story of block grafting, soft tissue grafting, failed grafts, redoing the grafts, placing the implant, failing, and then replacing. And eventually, they gave her a crown, which looked like this. When she questioned this portion of it, the prosthodontist said, this is grout. This is dental grout. She said, what's dental grout? She said, well, when you do ceramics, sometimes you get gaps between the ceramics and you fill it with grout. And when we do dentistry, sometimes that's what happens. So, that's when we put the grout to match the surrounding gum tissue. Now this patient needs a tooth number 9. This tooth is loose and needs replacing. And I want you to think, and usually when I ask how many people in the audience would tackle a case like this, I get no hands or maybe 1 or 2. And when I asked them, would you refer this to your worst enemy? And sometimes I get some people raising their hands. So, but this case, in the world of ULTRATOOTH, it's very simple. All I did is remove this tooth, prep the area, clean the area, prepped it, and placed an ULTRATOOTH and provisionalized. And this is 4 weeks later. Now I want you to compare the two sides. Look at the soft tissue. This is a tissue that I call angry tissue, inflamed, wants to reject everything. And this is a tissue I call happy tissue, which basically wants to hug everything. Look at the way it's hugging the provisional, even though it's acrylic. Look at the difference in color here around the old crown. Look at the bone level with the tooth, ULTRATOOTH placed 4 weeks later. Look at the bone level. And here, if you say this Lazaroff angles his x-rays to show his ULTRATOOTH are doing better, you can't deny this baby papilla coming in. You know, where there's bone, you get papilla growth. So here's where this was 9 weeks later. And at this point, I asked the patient if she would let me grind this pink stuff because it looked to me that this tissue kind of wants to drop down. And she said at this point, no, I'm happy exactly the way it is. I don't want you to touch anything. So we left it alone. And this is where we left off. So the fifth advantage here is that this ULTRATOOTH, again, the histological studies showed that the healing, the osseointegration occurs outside and inside the pods. So you have a 30% increase in the surface area of the device. So a 10 millimeter ULTRATOOTH has the surface area of a 13 millimeter screw. So this is another study that was done in France showing the bone that integrates inside. And perhaps the reason for cases like this, where this dentist sent us this case, had two different types of devices, and he used them down the line. And this is another one where this was type 4. When the ULTRATOOTH expands fully and the cone comes up, well, it tells us this is type 4 bone, and you don't load it immediately. All these were not loaded immediately, but when they were loaded down the line, the doctor sent us this saying that the 4-unit bridge was being held by that ULTRATOOTH by itself. Now, often when we use screws to tent and we have failures, we can save those failures by basically placing an ULTRATOOTH. And this is 1 year down the line. Now, these are 3 typical questions that are asked about the ULTRATOOTH: the removal, the seal, and as far as fracture. As far as removal, the device is designed to be fully reversible. So if it's not integrated, you can reverse it, the pods go back to its original position. So you can unscrew it. Now, if here's a case, a diabetic case where the device did not heal well and they wanted it removed, and we removed 2 of these. And basically what you can do is when you unscrew the center screw, we teach you in the course. Now, if it's integrated, all you have to do is tap on that center screw so it pushes that cone down. Now, by that expansion cone being down, the bone is pushed out, so the pods are no longer supported. So if the pods are not supported, when you send the trephine, the same diameter as the top, it goes down and closes the pods and closes the ULTRATOOTH just like this. Now, for those of you who want a device that does all of that, you just screw this on top of it and use a ratchet. On this, this goes down and trephines and pulls the ULTRATOOTH out. We have this device. We have not sold a single one of these. Now, as far as the implant seal, this was a very big issue that we had to answer, and we had studies by USC that were done in patient, measuring the bacterial count around the Sargon implants when they were placed, and then the FDA required us to do these tests in vivo tests where we expanded the implant different levels and put it in clear medium. They put dye into it, and in the ultrasonic, they wanted to see any of that dye would go through the implant, and they used spectrophotometers, and they showed that the device was completely sealed. But essentially, even though that was sealed, it meant that the doctor had to actually expand the implant to seal it. So at that time, this was the only part, and the rest of the implant was open. Now, we did have some doctors where they wouldn't expand the implant. They would place it and said it was stable. I didn't need to expand it. And if you didn't expand it, you did not initiate this cold weld that occurred right here by expansion. So this is why in the ULTRATOOTH we redesigned, since we didn't want our success rate to depend on the performance of the doctor, we designed the screw cap, which is basically your cover screw that always stays in, and it has a Morse taper. So it goes in here, and just by finger pressure tightening it, it seals here. And the characteristic of a Morse taper is that with time it just gets tighter and tighter. So as things move, it just works its way down. So this screw never gets loose. And then the third seal area, again, there's a Morse taper here, which I said the abutment locks onto and cold welds. So it's bacteriologically sealed. There's no movement. And if there's no movement between the implant and the abutment, the screw never fractures or loosens. And the purpose of the design was that I wanted a system that I would see the patient once and I could say goodbye to, because many patients that we treat here in our clinic fly in and have their teeth done and fly out, whether it's one or two teeth or full mouth cases. We do many cases such as that, and I never wanted these patients to call and say, you know what, the prosthesis is loose, it has to be tightened and all that. So since past 8 years with this design, you can confidently basically do a screw, a cemented crown, and say goodbye to the patient. So here's, we call this the triple seal design. Now, as far as the strength, obviously FDA wanted to make sure that this is strong enough, so they had us bury the implant to its midpoint and hit it with 6 million cycles, which nothing happened. And then when we continue to see if we continue where the failure would be, it was just like all other implants. It was at the bottom of the abutment screw, but this bending occurred at around 700 pounds per square inch on the average, and this was twice the original Brandemark implant, which was pure titanium. So as far as the strength was, very strong, and we do not get implant fracturing in function. Now, Morse taper is not new to dentistry. It's been used before, but because of typical implant design being the implant requirement being, bone level, below bone level, not wanting to put any pressure on it, the female Morse is placed inside. And with time, you can see if you put constant pressure on the walls of the implant, you get these flowering or fractures that occur. But we reverse this and put the female in the abutment because we have the luxury of being able to put load on the ULTRATOOTH, and we're not afraid of loading. So by having that abutment there and having the female in the abutment, we do not have fractures, but we do have all the advantages of the Morse taper. The hex is there for those doctors that want to transfer, to be able to transfer it, and have the lab do it, and basically for the abutment to come and go in exactly the same position. So everything that you want to do, if you want to do screw retain that you're used to doing with your typical implants, you can do them, even though we don't recommend it with ULTRATOOTH, because basically we want simplicity. Everything you need for that single tooth replacement is in that box, and that final abutment, that carrier, is your final abutment. You can cut it, put your provisional on it. You can even at the same time scan it. If you have a milling unit, put a final crown on it. If you want to put a cord and take an impression, you can do that and put a provisional on it while the lab is making it. So it's typical standard dentistry once this thing is placed. So as far as treatment indications, I'm going to show you a few more cases. I think, how are we doing as far as time, Mike? Maybe I have like maybe 10 minutes here. I'm going to introduce you to Dr. Blinstra. He is a military dentist that was serving in Arizona, and he was sitting in a bar where somebody comes in and punches him in the mouth and loses 4 teeth, 3 maxillary anterior, 1 lower, and actually fractures the palatal plate. As these teeth were pushed back, that palatal plate broke. So they took him to emergency. They wanted to remove that piece of bone and put him in flippers. And his father has been a patient of ours, so he was familiar with the treatment. And he said, no, stop, please send me to LA. So we saw him the following day in this condition. So when we scanned him, we could see that piece of bone that was hanging on the soft tissue, palatal soft tissue. And this was the condition. And he was treatment planned for 4 ULTRATOOTH. And you can see this fracture right here. This piece was loose, and then again, you can see it in this view. So basically, we placed 4 ULTRATOOTH and give him fixed provisionals. And we have so much stability with this that I took that piece of palatal bone with the soft tissue, sutured it around these ULTRATOOTH. So the patient went out with fixed provisionals, and then we asked him to send some pictures. And here's 3 months. I want you to see the bone. Now I want you to think about what would have happened if we didn't do this treatment and this piece of bone was removed. How much it would take to bring back what's here, how much time and surgeries, if it could be back. This is 1 year post-op, he said this. I wanted him to show more gum, actually showing more mustache. So, but he's very happy. You can see the papillary there, and actually, this is the 4th ULTRATOOTH right here. Molars can be replaced as long as you have some bone and the roots are diverging. You can go ahead and actually do the preparation through the tooth, which makes it easier cutting, finding this bone right here. And once the preparation is done, extraction is done, I can place a 13 millimeter ULTRATOOTH here and put full function on it. And this is 3 months later. Here's another case. Is this patient is actually the crown prince of Saudi Arabia, past crown prince, and he was flown here to our office. 2 visits, sedated. 1 visit for all the upper teeth, but another visit for all the lower teeth. This is a time of final restoration about 10 days later, and this is 4 years ago. So we can treat all kinds of cases with the ULTRATOOTH, anterior, posterior, full mouth, single teeth. In my practice, generally about 80–85% of cases, all the anterior aesthetic region is always ULTRATOOTH. I do have some screw cases. Patient comes in with a healed side posterior molar, doesn't mind waiting 3 months, doesn't want to pay the extra fee. I'll put a screw in there, but if it doesn't integrate, I'm not going to delay the treatment. I just put an ULTRATOOTH and continue the treatment. And sometimes if the patient's wearing dentures, they want an overdenture, put 3–4 screws. We do, use some screws, but generally, in my practice, practicing with this ULTRATOOTH for past 28 years, I have about 85% cases of ULTRATOOTH, about 15% screws. So we have all kinds of cases that we do, and hopefully when you take a course, we can go more deeply into treatments, placement. Essentially, the first course, we concentrate on having you be able to replace that single tooth. And as you get comfortable with that single tooth, you want to do larger cases, we have more advanced courses, and we go into those details. Are there any questions that I can answer? I see all the microphones are muted.
Oh,
Except
no. Hi.
hello, is this Stuart?
Yeah, I'm curious.
Everybody has the ability to
Have
speak.
you heard a case where the bone loss is so severe after bone transplant, bovine, human, whatever, you can't restore the bone? What do you do then?
You mean if the bone is completely missing?
Yes.
Well, that completely defeats the purpose. The purpose of the ULTRATOOTH is to prevent that from happening. But once that's happened, then you have to go through the traditional techniques of recreating the bone prior to placing the ULTRATOOTH.
How would you
That,
do that? Would it be bovine or bone graft?
oh, I see. For me to increase the width and some height, block grafting is more successful in my hands. Uh, bovine, I usually use that for augmenting, putting it in the sockets, and if it's a buckle plate missing, I use bovine. But for increasing width and height, I do block grafting.
All right. Well, thank you.
Sure. I see Dr. Healy unmuted. James?
Well, why don't we do this? If you guys have any further questions, please feel free to reach out to me. My name is Mike Stevens. I can be reached at 206-769-7700. Or Dr. Sargon Lazaroff, is there a way that they can reach out to you directly if they have a question they'd like to reach out to you about?
Text me, but put your picture with your text and your name so I know who I'm talking to at 818-388-9050.
All right, with that being said, we'll wrap up this call. I appreciate everybody's opportunity for joining our call today. Again, thank you, Dr. Sargon Lazaroff, for hosting this. We appreciate it, and be well. Have a good holiday, everybody.
Thank you, everyone.